Right, we will go ahead and get started. Hello, everyone. Thank you for joining us for health equity during a time of global crisis. We are looking forward to a great session today. A few logistical notes as we begin. This session is being recorded and the chat is being archived. Attendees are in view-only mode to keep things orderly, so you will not be able to use your microphone. We encourage you to use the chat box throughout the session to engage with the group. You can post here for technical issues you experience, as well as any questions you would like to share with presenters. We will share these questions towards the end of the session. The session uses auto captioning. While these captions will not be exact, we hope they can improve accessibility for all attendees. To activate these as a viewer, please look for an option on your toolbar that says live transcript and select either subtitles or full transcript, which will appear in a sidebar. Your options may differ on a mobile device. A recording of this session will be made available on our YouTube page. A quick note on professional development credits. If you are intending to claim professional development credit through South Carolina Endeavors for early educators, please complete the submission form we are about to share in the chat box before the end of this session. This is essential to having the information needed to process your credits. Remember that you must attend the session for its full 1 hour duration to receive credit. These sessions are also eligible for CME credits. Further information, including the link to complete your attestation form, will be sent in a follow-up email next week. For CME and all other professional development credits, ICS will be happy to provide verification of attendance. For that and other professional development inquiries, please contact John Conklin. If you have questions about this process, please return to the lobby in Zoom after this session where someone can assist you. And for John Conklin's email, it will be jconklin, that's CONCKLIN at instituteforchildsuccess.org. At this time, we're pleased to introduce ourselves as presenters for this session. So there's me, Mary Garvey, Vice President of Equity and Innovation at Institute for Child Success, and also Bryan Boroughs, our Vice President and General Counsel, also at Institute for Child Success. Great, thank you, Bryan. So we all wanted to make sure that we let you know why health equity is something that is so important to us at the Institute for Child Success. Really, it's because it is directly in line with our mission. We have a mission that is indeed based in equity, as we desire to pursue the success of all young children. Here you'll see the agenda for our session today. So we'll start off by doing a bit of an exploration of health equity and what that means when we use the term. We'll get into 3 categories that relate to the topic of health equity. So we'll first go through, delve into the impact of COVID-19 a bit, then racial trauma and its connection to mental health, and then we'll talk very briefly about the maternal mortality crisis. And then finally, of course, we'll wrap up with tools for changing and disrupting an inequitable system. During the presentation, there will be several chat with us slides, such as the one that is in front of you right now. And so these slides will indicate an opportunity for you to respond to the question or the prompt at hand as you engage with us and also with one another. So our first chat with us slide has the question here: what brought you to today's session on health equity? So feel free to kind of share in the chat why you're in this session today. What was it about this topic that really interested you? If there's something that you want to get out of it or something that you hope that we cover, something that you would even like to share with the group, this will be a great opportunity to do that. So please, do use the chat freely to go ahead and respond to this prompt, and just in general to engage with us as we move along, because we definitely want this to be a session that is as engaged as possible, given that we're virtual and not physically in front of one another.
Looking forward to being back in front of one another next year.
Yes, absolutely. Until then, we'll chat away. Okay. Yep. So thank you. We have a few responses already. Health equity is a topic I want to continually learn about throughout my career. Can never learn enough about it in general and how to promote it. We have another response. I'm working on a rural healthcare grant for individuals with disabilities and felt this session might be helpful. That's wonderful. Another response: I am a social worker. Social justice, equity, etc. is important to our profession. Yeah, this is great. So we'll go on. Feel free to keep putting your comments in the chat, and we'll continue along with our slide presentation. I see another comment here, interested in all aspects of equity for our children. Thank you. So when we talk about equity, here you'll see some of the various definitions of the term equity before we even get the word health combined with it. This particular definition is one that we love to use at ICS, and it is from the Race, Equity, and Inclusion Action Guide that the NEEKC Foundation published in 2014. And so the things to note here is that there are some sentiments of fairness and being just, living full lives, also kind of meeting people where they are so that these things can happen. So when we think about then health equity, the Mary Black Foundation has done a really great job in their health equity framework of kind of putting all of these things together as they relate to health. And so here we see a focus on having access in order to thrive. So both access and thriving. And we also see a focus on health and wellness without limits. And so when we think about what some of those limits might be, we know that in order to get to a state of being equitable, these things should not be barriers to access. They should not be barriers to wellness or barriers to being healthy in general. Oftentimes, the social determinants of health that you see listed here act as a guide for determining the quality of one's life and well-being. So these are the 6 categories that are generally considered: economic stability, neighborhood and physical environment, education, food, community and social context, as well as health and the healthcare system. So it's generally thought that thriving in each one of these areas is what then leads to having a healthy person, whether it's a healthy adult, a healthy child, a healthy infant. Okay. So now we're looking at this slide that says evolving from the status quo. And so oftentimes when we ask the question, hey, you know, when you hear the word equity, what do you think of? People will say the people on the boxes or the kids standing on the boxes. And so this is the image of the people. I don't know if they're children, but they're standing on the boxes, right? At least in the first and second frames, they're standing on the boxes. And so when we look at the first frame of the status quo, everyone has the same box. And, you know, we have one person that can't see at all. Their view is completely blocked. Another person that can see, but not, you know, they can see. And then of course we have one more person who can really just see everything, because this person is just really naturally just very tall and can see above whatever barrier is there in the first place. In the second frame, we see what is considered as being equitable or equity. It's finally realizing that the one person who cannot see perhaps needs a little bit more than the others, and another box is added for them to stand on. And of course, when we look at the third frame, this is what's considered as the ideal. Equity, of course, involves helps and supports, and as we said before, kind of meeting people where they are to give them what it is that they need. Whereas systems change in that third and final frame that we see that's all the way to the right is indicative of a system that is functioning so well that those supports are actually no longer necessary. And again, that is our ideal, and that is what we're referring to as systems change. And so you'll hear us talk throughout this presentation about systems and disrupting systems and things that are inequitable and systemically so. Okay, I just want to make sure I see a comment in the chat from Jamaria Williams saying I'm unable to complete the form, BabyNet intake coordinator. I just want to make sure, just bring attention to that. All right, and so I will pass it along to Bryan to talk about the impacts of COVID-19.
Thank you. So of course it would be the topic of mind for the last decade that has been 2020 is obviously COVID-19, and the health impacts have highlighted a number of health equity issues that have been systemic in our society. And just to kick off the conversation, I'm curious how many, so a lot of us work in fields where we see health equity issues directly. And I'm curious, we're curious if you have any stories that have particularly impacted you that you would like to share about the impacts of COVID-19 and how they've highlighted or revealed or illustrated health equity issues in your daily work. So if you do and you'd like to share those, please pop them in the chat box now. I'm going to go ahead and pop over to this one, just real top level. When we're looking at the key indicators of COVID-19, often described as cases, hospitalizations, and death. This is a analysis that was first cut by the Kaiser Family Foundation, where they took the rate of death and disaggregated it by race and ethnicity. And as you see here, so the way that works out is, and this is age adjusted, so it's comparing people of the same age to one another. And what you see here is the rate was benchmarked at 1 for whites, and then you can see the other races and ethnicities and how they are experiencing more or fewer, in one case, cases, hospitalizations, and deaths. And it's really rather stark, especially when you look at the disparate impact. So in terms of infection, in terms of cases, whites and blacks in the United States are experiencing about a similar rate of infection. But then the health outcomes change rapidly when you start looking at hospitalizations, where Black Americans are 2.5 times more likely to wind up in the hospital once they're infected. And they are 1.7 times more likely to die from COVID. And you see similar impacts with American Indian and Alaskan Natives, and also some similar with Hispanics. We know that a lot of folks who are here in this session are from South Carolina, so we also just pulled this real quick on the South Carolina data, and you see it's a similar picture. Blacks are more likely to experience death from COVID than whites or other demographics. In South Carolina, it is more pronounced for the Black community than it is for other races and ethnicities. But it's really quite pronounced, the disparate impact once a person is infected with COVID-19. There's also the gender dynamic on COVID-19 impact. So from a pure health outcome discussion, or maybe I shouldn't say pure, but in an immediate health outcome perspective, men are more likely to die from COVID than are women by about 55 to 45 ratio. But the impacts are more complicated than that. When you start looking at the not immediate health outcomes, and you start looking into economic issues, especially, women have been dramatically more impacted, especially from a workforce perspective. And as Mary mentioned just a few slides back, one of the social determinants of health is financial stability. And what we're watching here is a very significant disparate impact on women on sources of financial stability. So you see here the total for all adults, about 19.6, for 25 to 44, about 25.5. Then you break it out into women and men of the same age groups, and regardless of age, it's a very stark difference. So that's just a very top level. I'm not seeing a lot of folks wanting to engage in the chat on the health equity impacts from their daily job. And maybe we're all a little too close to it right now to get into that in a chat window. But feel free to dive into that if anybody would like.
Bryan, there is a comment
yes.
here from Jerry that says, I have had many encounters with health inequity in my near 50-year career in pediatrics, but one that burned this fact into my soul was a young girl who I saw in the free clinic that would treat her asthma attack by breathing cold air through a hole in the roof. This is an advanced, wealthy nation. Yeah, that's really shocking. Thank you for sharing that, Jerry.
Yes.
Okay, so we will move on to our next subsection on racial trauma and mental health. So in the spring of 2020, at what was considered the very public height of racial tensions, as well as the height of the COVID-19 pandemic, when we were all still trying to figure out what was going on. I mean, I think we're still trying to figure that out 2 years later. But at that point in time, ICS reached out to approximately 100 parents and guardians of Black children, and just wanted to kind of get their stories about that moment in time and what they were feeling, what things were like in society for their Black children at that moment. And this is one of the questions that we posed. Basically, we wanted to know if recent events made those parents and guardians feel more worried about their Black child's future. And so they had the option of selecting yes, no, or unsure to this question. So as we think about the ramifications of racial trauma and the things that we're seeing at that time, the very visible protests that were happening in every state in the country and really globally as well. We were seeing them in other places as well, and the different killings that happened at the time. What impact, witnessing those things and just the day to day as walking around as a Black person, as a Black young person in this country may have had, what the impact might have been on children. So if we could go to the next slide. So what we saw as far as the topic of whether or not there was increased worry about their Black child's future is that 89%, so the overwhelming majority of adults who were questioned about this said that yes, they did indeed feel a sense of increased worry. And we can only sit here and imagine, what led to that feeling of being more concerned about a child's future, given everything that was going on at that particular time. And noting that, it's not like those sentiments have ended or that they didn't exist before that moment, but really just that they were really highly televised at that particular moment in time in the spring of 2020. So just something for us to note and think about. So here we'd like you to go into the chat once again and share with us, have you witnessed the impacts of racial trauma on the mental health of children and or their adults? Any thoughts that you have on this particular topic are welcome, and we can kind of discuss them with one another as we continue. So many of us who are in the fields of early childhood have heard of and are familiar with the term ACEs, or adverse childhood experience. There has been a growing movement over the years to look at these adverse childhood experiences, or ACEs, through more of an equity lens. Basically, it has kind of responded to the question, should racial trauma and racism be considered an adverse childhood experience? And, if not, should it be considered just as important, just as potentially traumatic to children as ACEs? And I think that many of us would say that the answer to that is yes, absolutely. And so right here, you see a kind of reimagining of this ACEs pyramid, and some of the things that you might want to note that were not in the original pyramid. You'll see on the right-hand side that now it incorporates things like microaggressions and implicit bias. Just a couple of terms that may or may not be unfamiliar, and I want to make sure that I put this out there in terms of what they mean. So you'll see the term here that is listed as epigenetics. The Center for Disease Control defines epigenetics as the study of how your behaviors and environment can cause changes that affect the way that your genes work. We also know scientists told us that these changes are reversible. So it's a good thing that they are reversible. And so one other term that we will see here is allostatic load, and that refers to the impact of repeated or chronic stress on the body and overall health. So again, those are just some interesting and relevant terms as we discuss mental trauma and just thinking about adverse childhood experiences through more of an equity lens. Amina here has said, yes, she has seen the impact of racial trauma, increased anxiety for children of color. I had a 10-year-old therapy client who was anxious around officers, including walking around Target and seeing security officers. That is a common thing. Thank you for sharing that, Amina. Very, very much so. Unfortunately, a common thing. to be nervous around officers. Thank you for that comment, Edward. Great additions, referring to I believe the the pyramid that we just saw, reimagined pyramid. And so now, when we think about implicit bias, which is, as many of us know, it is the idea that we have these preconceived notions and stereotypes or biases about people that are not based on, that may not be based on facts, because they're based on stereotypes and what we think our observations are. And so these biases, a lot of times we don't know that we have them. So another term for it may be unconscious bias. There are also, of course, conscious biases and outright racism and bigotry, right? But this thing called implicit bias in childhood trauma. So we see some links here. So when we look at the social conditions and things that may be happening in society, and then we link it to implicit biases that may occur, whether in the classroom or just generally in society, we then have a case of what we call PTEs, or potentially traumatic events. All of these things combined and on top of one another could lead to a child or children who are very much traumatized, excuse me, and experiencing these PTEs or potentially traumatic events. So we have another response here from Carrie, also saying yes, definitely, in terms of racial trauma and the impact on children and or their adults. It says, Black youth that I care for have absolutely identified racial trauma as a trigger for their anxiety. Thank you for sharing that. Very important information. So PTEs and increased stressors. So here we see that if racial trauma is indeed one potentially traumatic event, here are some of the things that can result, and basically some of the impacts as we're thinking about mental health. So we've already heard some of you list, 2 people already have listed anxiety. So that is here. It is something that is documented in the research. We also see depression. We see suicidal ideations and actual suicide, as well as lower self-esteem. And those are just a few of the potential ramifications of these stressors. Maternal, okay, so now we will turn to maternal mortality. Please do keep your comments coming, even if we pass the section that you wanted to respond to, that's okay. It'll be an ongoing discussion. All of these things are related to one another, so that is more than okay. So Bryan, there is a video for this section. Originally, I know that we said, we would just play a short clip of it. I think that we're actually a bit ahead of schedule. So if you want to play a bit more of it, that would be okay. Not just yet, but okay. Just letting you know that it's okay to play more of it. I just want to go to the comments. So Carrie has also said, and the severity of suicidal attempts are staggering, meaning the attempts are much more severe. Thank you for noting that. I think that sometimes there is this idea that if an attempt is not quote unquote successful, which is not the best term to use, then, oh, well, it wasn't that serious. They didn't mean it. They didn't really want to die. Therefore, it must not be that serious, right? It's almost like, oh, it's just a cry for attention. And it doesn't really mean that something serious is really going on mentally, which we know is false. So I'm really glad that you've pointed that out, Carrie. And Amina has added, I think the combination of COVID-19 and racial trauma contributes to the severity of attempts, as well as the increases in attempts in general. So thinking about the toll that both COVID-19 and then this ongoing racial trauma have added to children, to all of us, but really when we think about young people who are still really trying to get a grasp of their emotions and learn how to deal with these difficult emotions, and just learn how to exist in this world where these unprecedented things keep happening, right? It's a lot to handle at one time. So I think Carrie and Amina have both made really, really excellent and relevant points.
And I know we have a lot of doctors in this conference, and we also have a lot of folks who are really from the education space and the early education space. Mm-hmm. And one thing I'd like to echo from Carrie and Amina, I'm hearing that from every healthcare professional I know, that they're seeing tremendous
uptick in both severity and number of suicidal cases.
Yeah, it's definitely, some of these statistics are staggering. Okay, so as we move on to our third focus area here, we'll touch a little bit on the legacy of Dr. James Marion Sims, who is known as the father of modern gynecology. But what we actually know about James Marion Sims is that he experimented on enslaved women and children in the 1800s and is also known not to have provided anesthesia. And I think that this is really important context as we for the next few slides, where we'll see some evidence of how women in general are just not treated well sometimes when they do go in for childbirth or just generally along in their pregnancy. And while that's not every woman's experience, every woman, every person giving birth does not have a negative experience, but we know that there are definitely some issues there, and that there is indeed a maternal mortality crisis. And it kind of sets the context and background for the fact that some of these things have really been going on for a very long time. And that, you know, and it begs the question, how could this man be called the father of modern gynecology? Why don't those lives matter? Those lives that were traumatized and mistreated. Just another comment here. Instead of the word unsuccessful, successful attempt, I have been trying to say something like did not die by suicide. Terminology is difficult. Thank you, Amina. That's really good language for us to consider.
It also harkens to the died by suicide rather than committed suicide.
Yes, indeed. And then Barbara has noted, and not enough mental health resources to meet the demand. Yeah, that is, you know, especially when we think about schools, I think that has been an ongoing issue, that there haven't been enough mental health resources in these schools. And then when now they're even more necessary, there's still a lack of these resources. So now they're even more needed. And we've already started from a place of lack in terms of not having enough mental health resources. So yeah, thank you for pointing that out, Barbara. So I want to make sure that I put a trigger warning out there before we play this video. Some of this content is difficult. It does deal with, you know, as you see, mothers in crisis, when giving birth. It's a difficult topic. So, you know, I want to throw that out there, and I just, you know, want to say that it could be a trigger for some. Just a few more comments here. Access is limited for all, especially low-income families. Indeed, yes, there is. Unfortunately, a lot of times mental health counselors and just general resources in mental health is considered a luxury, as opposed to just something that should be available to everyone. And then the acuity is increasing. Yes, absolutely. Okay.
All right. Shall we hit play?
Yes, we shall.
Okay. And you still want me to start at the same point?
Yes, you can start at the same point, and we can play the whole thing from that point.
Okay,
yeah,
great.
That's fine.
Okay. Almost there. Okay. Here we go.
This, Brian, can you turn the sound up on it?
I don't know. We'll see.
We're not hearing anything.
Oh, you're not hearing anything.
No.
Okay, I'm gonna hit pause. See if I can fix that. So on mine, it says that the volume is up. Let me see if there's let me make sure the screen sharing option.
Okay, while you do that, we have a comment here from Jerry. Whatever happened to mental health being equivalent to medical health as to insurance? Yeah, it's definitely an issue. It's definitely a huge issue, and that's a good question. And then we have from Linnea, also may want to share audio, video, the advanced settings.
Yep.
I think that's a tip for you,
Doing
Bryan.
that now. Okay, let's see. Give me a thumbs up, Mary, if you hear this when it starts going.
Can bleed to death.
Yes.
Dr. Neil Shah is a professor of obstetrics at Harvard Medical School
The pain is okay.
and a practicing physician.
Are you also saying that some of these C-sections are just not necessary?
Probably more than half of them.
And when complications do arise, says Dr. Shah, doctors don't always listen to their pregnant patients.
I think there is a dimension of gender discrimination. If a woman after a birth goes into a hospital with concerning signs of a complication, there are no rules for how quickly an obstetrician has to see her. And in fact, it's a routine case that it will take hours.
And statistics indicate that it may not just be gender that plays a part in dangerous delays, but also race.
If you're a woman of color in this country, especially if you're Black, your odds of dying in childbirth are 3 to 4 times higher on average in our country.
Why? Because you're not talking about access to healthcare. You're not talking about money or education.
No, and this is going to be hard to hear. We believe Black women less when they express concerns about the symptoms they're having, particularly around pain. And that's the common thread in all the stories we've been hearing in the media, including Serena Williams.
Yes, even Serena Williams, the world-class athlete who developed a pulmonary embolism after giving birth to her daughter last September.
We had a lot of complications, but look who we got.
She says that had she not insisted on receiving a CAT scan, she could have died.
We're leaving the hospital after 7 days, 6 days. It's been a long time.
If women with resources are at risk, imagine what happens to women without access to proper health care.
I am this baby's big sister, and this is my mom.
My first proper prenatal visit was at 16 weeks. It was terrifying. I had been bleeding for about 11 weeks before I was able to get a understanding to why.
Mom, you can't play on it.
32-year-old Akila Collier works as a full-time substitute teacher in Orlando, Florida. But she couldn't afford health insurance when she became pregnant with her second child.
I went to the emergency room, and that's where I got my prenatal care for the first 3 months. I racked up over $20,000 in medical bills during those 4 visits, and they misdiagnosed me every single time. They were saying that it looked like I was having a miscarriage.
And there's 30-year-old Ashley Lacayo, who also lives in Florida.
I have insurance, but I've never been told no so many times by people who are like, have no emotion. Oh, I'm sorry. No.
Lacayo says she initially was able to get prenatal care by agreeing to pay her entire deductible, $2,600, by her 28th week of pregnancy. But when that date rolled around and she couldn't afford the full amount, her doctor refused to continue to see her.
I called 15 or so different clinics in the area. Everyone denied me. It was just a never-ending, how far along are you? Oh, no, sorry, we don't accept patients past 25 weeks.
There you are. Oh, I got a kick here too. Women are literally shut out, left wandering the streets, trying to find someone who will help them and running to the emergency room in lieu of prenatal care.
Midwife Jenny Joseph, who moved from London to Florida nearly 30 years ago, says she is deeply concerned by the number of women who are shut out of proper prenatal care.
We are standing by, literally, as mothers and babies are suffering. And I feel like my little piece is to be able to make a difference in that.
In 2006, Joseph opened a practice specifically for them, called the Easy Access Clinic.
So you are the big sister.
It's run by nurses and midwives who include doctors when necessary. They turn no one away.
There isn't anything you can come up with that will have us say no. You can be indigent, you may be homeless. We're still going to see you. And the simple reason is because you're carrying a baby. Like, what else would we do? There isn't any, I think, ethical way to say no, go away. How's baby moving? A lot? All the time. That's what
2 months after being refused treatment by her first doctor, Ashley Lacayo heard about the clinic. Joseph saw her the next day.
Wow.
This place saved me. It did. I mean, I'm doing a week, and where would I be without her?
Both Lacayo and Collier gave birth to healthy babies in May. But this problem is not going away. Since 2000, hundreds of hospital maternity wards have closed across America. Low-cost clinics like Joseph's could help fill the need, but she warns that may not be enough.
Women are sent out of a hospital 2 days after they've delivered and basically told to wait for a 6-week postpartum check, which is useless to them, given that most of the postpartum concerns, the morbidity and the mortality, occurs within the first couple of weeks after the baby's born.
But when deaths do occur, Dr. Atiabet from Merck for Mothers says each one must be counted and investigated.
Is that being done right now?
It's not being done in every state, so they're not paying attention to the issue. They're not only not going to know that there is an issue, they're not going to know how to solve it.
Slide.
More than 2 years after his wife Kira died, Charles Johnson is now a single dad, raising their 2 sons in Atlanta.
Woo! Let's go, Vincent. We're winning.
Determined to keep her memory alive, he's suing the hospital and speaking out, hoping to put a face, a deeply missed face, on an American crisis.
It's immeasurable how much I miss Kira. And particularly as I see these amazing gifts that she's left us with. And there's so many things about our journey together that are bittersweet, but they're so painful because she's not here to share them with us.
Do you think Kira's death probably means other mothers will get better care?
I hope so. When you go into the hospital, ask them, do they know about Kira Johnson's story? Ask them, do they know about what happened to her? And then ask them directly, what are you doing to make sure that the same thing doesn't happen to me?
Thank you, Bryan. There was a lot there. That was very heavy. But also really important. And so here is a quote that really sticks out to me every single time that I've watched this this CBS piece. And there's a source at the bottom of these slides. These slides will be made available to you after NDM, probably early next week. And so, you know, if you're interested in this documentary, definitely feel free to go on and watch the entire thing. But Dr. Neil Shah, who was interviewed, said something that is, again, just jarring. And so I think that many people's experience know this to be true, but to hear a doctor, a man, and someone who is not Black say this, it really shocked me to my core. And so he said, we, referring to doctors and medical professionals, believe Black women less when they express symptoms they are having, particularly around pain. And I think it's such important context when we go back and we think about that slide previously about James Marion Sims and, conducting these procedures without anesthesia. And it's just the idea of just not valuing Black bodies. But we also know from this documentary, and even just a short clip of it, that we saw that maternal mortality crisis is not, it is something that goes across races and across socioeconomics. But we do know that it is a bit more dire when we think about Black women and women of color. Black women are 3 to 4 times more likely to die from pregnancy or childbirth-related complications, and are also less likely to give birth in the safest hospitals. I want to say this is 23% of Black women versus 63% of white women give birth in the safest hospitals. And if I recall, when I originally kind of dug into this research, there wasn't a big difference across socioeconomics, meaning that even a Black woman who was a bit wealthier and of a higher socioeconomic class didn't necessarily mean that she would end up in a hospital that was safer. Okay, so before we get to the next section on tools for changing the system, things that can help us, because again, this is these are some very heavy topics, and we want to know that we can equip ourselves to disrupt the system of health inequities. I do want to go back and look at one other comment that we have from Holly. Again, when we're talking about suicide attempts, not only the suicide attempts, but the non-suicidal self-harming is increasing significantly, as well as the seriousness of self-harming behaviors. Yes, thank you. Thank you for sharing that.
All right. Shall I dig into some tools for changing the system, Mary?
Yes, you shall.
All right. So we're gonna walk through four different, very quickly run through 4 different frameworks for how you can think about systems change. I'll say this at the outset. This is enough to whet some appetites and help begin to address how we think about the issues that we're facing. But there's a lot more to dig into here. So we have some references for you if you want to dig further, and also we occasionally do trainings on systems change itself. So feel free to reach out about those. But the first one that we start with always is the parable of the river, and I wish we had the ability for the raised hands thing, but some of you will have come across this. Especially, I noted that some folks were here from social work. And this was actually created by, and I'm forgetting his name right now, but one of the earliest social workers. And it's the story about, so there was this town beside a river, and one day somebody was sitting on the side of the river and saw a kid flowing by, it, having difficulty staying afloat, and was about to drown. And so this townsperson goes into the river and gets out the kid. And in classic social work style, now you have this kid who doesn't have a home, is displaced, is traumatized. And so the story goes, they start setting up. They find a foster system. They get the kid to healthcare. They take care of that kid, and they set up structures to take care of that kid. And then while they're working on that, they see another kid floating down the river, and they go get the kid. And this keeps going. And after a while, they have people whose jobs is to sit there and catch kids who are coming down the river, and to get them into that system. And one day, one of the folks who's doing that, who's standing on the side of the river watching for kids, he gets up and leaves and starts walking upstream. And people are like, "Wait, what are you doing? Where are you going?" And this particular future systems change person says, "I'm going to figure out who's throwing the kids in the river, because we've got to stop them." And this is the idea of both how social work is so critically important and saves lives every day. And also, we need to not just be responding to the traumas that are occurring and trying to intervene and more, but go upstream and try and prevent them in the first place. And so that's the sort of mindset shift towards the systems change. And thank you, Mary. I was about to flag that somebody was asking for the name of that documentary. So that's a way to think about systems change in general, and going upstream as a metaphor. But then there's this other one that's fairly common, especially for those of us who have engaged in philanthropic partners. And it's the social ecological model. And sometimes one of my dear friends at the Mary Black Foundation likes to call it the nested eggs. But it's this idea, basically, that it helps communicate that everything is related to everything else at scale. So at the individual level, with the smallest impact in terms of number of people, but sometimes very significant impacts for the individual. And then you have interpersonal, institutions, community, structures, policies, and systems. And all of them have impacts back and forth. But if you're trying to get at making sure that all children are successful, you really have to also look at those structures, policies, and systems. So how do we dig into those? So there are two frameworks that I want to talk about for folks who are interested in digging into this further. One is from the Waters Foundation. They created a set of tools for thinking about and working on systems change called the 14 habits. And it's their habits of mind, habits of thinking for people who are working on systems change issues. And the second one is Peter Senge's 11 Laws. So this particular author was the author of The Fifth Discipline and some other things where he talks about and I think actually the 11 Laws were first about learning organizations, so organizations that are continuously improving their quality. But they have since been adopted into systems change thinking more broadly than within a single organization. And also there's a corollary book, so to speak, for nonprofits in particular. There are two of these 11 rules that I find come up in every conversation about systems change. And so I did want to take just a quick pause and look at these two. The first is that causes are not always closely related in time or space. And so, for instance, the kid floating down the river was not floating down the river because of something that happened right there where they were pulled out of the river. The example, and it's a little hard to see maybe on the screen, depending on how well it's zoomed out. The example here is of a cavity. So the cause of the cavity isn't something that's close in time to the dentist visit where it's discovered, or even to when the pain is felt. It's also not close in space to the dentist's office or wherever it was felt. It's more related both to the sugar perhaps that was in the diet, but also in the absence of brushing and dental hygiene. But those things aren't necessarily obvious unless you fully understand what's going on with the teeth. So if you're just coming at this problem because you see that there's a weakness in a tooth and you don't understand all of the things that feed into that, then your solutions are going to be really limited and you're not going to be able to prevent those cavities. And the examples of this are more numerous than we can count, but it's one that comes up in basically every systems change conversation that we've encountered. And the other one that is also really important to pay attention to is this principle that the harder you push, the harder the system pushes back. And that has to do with, if you were going back to the cavity example, if you were to say, okay, let's just pluck out every tooth that has a cavity, that has all sorts of other dynamics that that come into play. But the example that's used in the tile for these 11 rules has to do with, if you have a car that breaks down because the water overheats and you're trying to get at it now, you're trying to get at it quickly, and you're trying to apply as much pressure as you can to get it done quickly, you might wind up just destroying the car if you start, for instance, hammering at the container of water. So the principle, it comes up most often when you are trying to attack those problems sort of head on, again, without thinking about all of the causes that lead to that phenomenon that you're looking at. If you're just trying to deal with the symptom, the harder you push on that symptom, especially, oftentimes it creates a backfiring mechanism that you wouldn't necessarily expect. I will say these habits of systems thinking and the law and the rules that go around it, they're incredibly rich and incredibly useful. And so I commend them to you all if you're interested in this topic. And feel free to reach out as well on those. Also want to flag that anyone who's familiar with continuous quality improvement, there's Six Sigma, there's Plan, Do, Study, Act. The American Hospital Association has adapted that mindset of the learning cycles of systems and applied it specifically to health equity during the times of pandemic. And this was their framework. So I wanted to highlight that. And it goes share, educate, leverage, analyze, and advocate, and repeat. And we do want to also come back to this concept of the social determinants of health. Very often when we are thinking about healthcare, even if we know that social determinants of health are incredibly impactful and, you know, in some cases can have dramatic outcomes on health outcomes, or a dramatic effect on health outcomes. It's easy for us, especially for those of us who work in or adjacent to medicine, to think about healthcare as the place to go for health impacts. And you know, these social determinants are incredibly impactful. And I think we may have Dr. Cease, yes, was in the audience. One of the examples that I like to use when discussing social determinants for improving health outcomes is a project that Dr. Cease at Prisma has worked on called the Medical Legal Partnership. Worked on, led, helped create. Sorry, I didn't mean to minimize your impact on that one, Dr. Cease. So but it's a thing where, you know, the sort of classic case study is a kid comes into the ER with an asthma attack, treat the asthma attack, it's a $5,000 bill, the kid goes home, and then the next month comes back with an asthma attack, and this repeats. And you could, from sort of a healthcare mindset, you could just keep treating that asthma attack. But what the Medical Legal Partnership does is it takes it the next step and says, wait, what's going on in that environment? And, you know, if it's in the classic example, the kid's living in a house with a lot of black mold, and that mold is triggering these asthma attacks. And so we could, as a society, we could just keep treating that asthma attack for $5,000 a month, or we could send an attorney could send a letter to the landlord and say, hey, by the way, you have to fix this mold. And if we do that, then we generate much more enduring and much more potent and positive health outcomes for the family and the society. And I see a comment here from Dr. Cease. Nancy Powers is the original MLP physician. She gets all the credit. And thank you to Dr. Powers, especially if you're here. And don't let Carrie fool you. She has done a ton of work on this as well, and we are eternally grateful for it. And Mary, should I pass this back to you for this one? I think you're on mute.
I am. I was
There
saying, sure.
Okay.
So I will do this slide and then go to a couple of the comments. So just a reminder that access does not equal inclusion. I actually borrowed this phrase, which is spot on, from a book written by Anthony Abraham Jack called The Privileged Poor. And it was dealing with like college admissions and just being in college, and the difference between being someone who is privileged and poor versus just not having money. And so, you know, highlighting the value of access, but then also of inclusion. And so just thinking about what it means, as we think about what it means to be equitable, and what people's experiences should look like to ensure equity. Inclusion involves both having, or I shouldn't say both because there are three things, but it includes having a quality experience, includes having one's voice heard, and also experiencing a sense of belonging. And so here, there is a comment here, several comments here. Is anyone aware of social determinants of health assessment measure as a more formal way to determine the impact of on a presenting concern? So I am not, but there might be someone else who is a participant today who can respond to that. Okay, I see, yes.
I think someone did, yep.
Okay, wonderful. And Annie Martin's the social work intern. Okay, wonderful. Okay, good conversations happening here. Great, I'm glad that was handled. And so, you know, this advocacy slide really stresses the importance of making sure that we are listening to the communities that we're in, the communities that we say that we're serving, that we say that we are trying to help. So what do communities say that it is that they need? You know, educate others, talk to neighbors, you know, talk to people, pass the mic. There's value in research that's in textbooks and ivory towers, but there's also value in the research that is lived experience, and we shouldn't downplay that importance. So as we look at these different social determinants of health that have been impacted, economic stability by COVID-19, community and social context when we talk about racial trauma and mental health, and then also the obvious, which is healthcare, when we talk about the maternal mortality crisis. These are some tools that we should be thinking about using in our day-to-day as we look to tackle health inequities and other inequities as well. Next slide. Okay, so we are about to wrap up here, and we have one more opportunity for chat with us, and also feel free to put any other questions or comments that you have in the chat. But this particular prompt here, we are curious about what your experience has been. What advice have you given or received on how best to tackle health inequities in day-to-day life? We think that would be a good note on which to end, just in terms of knowing what we can do as we move forward. So it could be something that you learned here today, or just something in general that you have made use of. You've either given the advice or received the advice and found that it's been really useful. Okay, I'll wait for responses to come into the chat. And so again, just highlighting evolving from the status quo and what it means. Bryan has gone through some of those tools of disrupting an equitable system. And this is a reminder that systems change means that we no longer have to just rely on, okay, well, let's get some more boxes, let's get some more supports, let's, but we start to think, why are these barriers here in the first place? And what can we do to remove them? And that is our ideal, especially as we think about the impacts on young children and their families. Oh, thank you, Sylvia. Have a nice comment here.
And for those who don't have the chat window open, if you're interested in the social determinants of health screener, Carrie Cease has put in a couple of links to PDFs that are downloadable from the internet. So if you're trying to get to that screen, we'll hold this open for a minute after we run out of time, so that you can get into the chat window and check that out.
Thank you, Bryan. And so I see a comment here from Lisa in response to the prompt: partner with families, approach assisting them from a strengths-based perspective. Historically, we try to fix without partnering with families. Yes, so important. That's correct. Okay, and so we have a reminder here about professional development credits. If you are looking to receive credit for attending this session, and what you can do in order to make sure that happens. You're welcome, Amina. Thank you all for joining us here today. We really appreciate your level of engagement, and we will be sure that these slides are made available to you all. And the slides that have sources are linked at the bottom of each one. So yes, thank you all for joining us here today, and feel free to reach out to us anytime after this session if you have any questions or you want some more resources.
Thank you, everybody. Really enjoyed having you.